Hello, my name is Christoph Wanner, and I'm a professor of medicine and head of the Division of Nephrology at the University Hospital of Würzburg in Germany. It is my real pleasure to welcome you to this discussion about unmet treatment needs for patients with type 2 diabetes and chronic kidney disease, and how nonsteroidal MRAs may impact the treatment paradigm. Today with me is Professor Janet McGill. She's a professor of medicine in the Division of Endocrinology, Metabolism, and Lipid Research at Washington University School of Medicine and attending physician at Barnes Jewish Hospital in St. Louis, Missouri. And also with me is Professor Javid Butler, the Patrick Lehan Chair in Cardiovascular Research, Professor and Chairman, Department of Medicine, and Professor of Physiology at the University of Mississippi Medical Center. Hello to you both.
Great to be here.
Yes, thanks, Christoph.
We have an agenda today, and the 3 points are: why does the treatment landscape for patients with type 2 diabetes and CKD still require novel therapies? And why are non-steroidal MRAs being investigated in patients with type 2 diabetes and chronic kidney disease? And what do the latest data show? And third, how might non-steroidal MRAs address unmet needs in type 2 diabetes and chronic kidney disease and fit into the current treatment paradigm? So let's start the first question and topic. Why does the treatment landscape for patients with type 2 diabetes and CKD still require novel therapies? And I think it's best that we look at the comprehensive management of type 2 diabetics and chronic kidney disease patients to reduce risk of kidney disease progression and cardiovascular disease. And we just look at recently published guidelines in the nephrology field from KDIGO, Kidney Disease Improving Global Outcomes, well accepted guideline body for patients with type 2 diabetes and chronic kidney disease. And certainly, we all discuss standard of care first with our patients. And standard of care includes glycemic control based on a combination of mainly metformin and SGLT2 inhibitors for type 2 diabetes. But there is also a focus on blood pressure control with target we have to achieve. We focus on lipid management in our high-risk patients, and always in the standard of care, we include exercise, nutrition, and smoking cessation as a complex package. When we go to pharmacological intervention, since about 20 years, our knowledge is based on trials which are using RAS blockade, including ACE inhibitors or angiotensin receptor blockers. And these agents are recommended for patients with diabetic kidney disease, albuminuria, and hypertension. And with the recent trials on SGLT2 inhibitors, KDIGO recommend these intervention on eye side with RAS blockade, best in combination with patients with type 2 diabetes and chronic kidney disease with a glomerular filtration rate above 30 ml per minute. And if further glycemic control is required, then a GLP-1 receptor agonist may be added for glycemic control when needed. Several patients require dual or single antiplatelet therapy, and mostly those in the area of secondary prevention with acute coronary syndrome or percutaneous coronary intervention. So, this is standard of care and modern organoprotective treatment. So, let's proceed now and discuss this scenario. And we should answer several of the most important questions. And I would like to maybe address you, Janet, and you can give me your view on the burden of disease that you see in your patients with type 2 diabetes and chronic kidney disease.
Thanks, Christoph. As you well know, our patients with type 2 diabetes have an unremitting risk of loss of kidney function manifested as either the presence of albuminuria or progressive loss of their kidney function, or both together. And recent NHANES surveys suggested that 26% of patients with type 2 diabetes have this risk despite better control of A1C, of blood pressure, and of lipids. So this is a significant problem for patients with type 2 diabetes.
So, thank you, Janet. Perfect description of these patients. And if I'm coming back to the treatment approaches you are using for slowing progression of chronic kidney disease in patients of type 2 diabetes, what treatment approaches actually do you apply and prefer?
So currently we start with the best glycemic control that we can manage, avoiding hypoglycemia. Secondly, it's blood pressure control and use of ACEs and ARBs. More recently, we are adding SGLT2 inhibitors to patients with either declining kidney function, albuminuria, or the presence of both. And most importantly, we follow these patients very closely to monitor their kidney function.
And these treatments you are describing, I often use the word organoprotective treatments. And maybe I ask now, Javed, if you applied these treatments, did you find any limitation with these current treatments, for example, ACE, ARBs, SGLT2, or even GLP-1 receptor agonists when you use them in type 2 diabetes and chronic kidney disease?
Yeah, well, thank you, Christoph. Let me actually take a step back and give a little bit of a cardiovascular perspective to your first question about the burden of disease. So these patients, with type 2 diabetes are at a higher risk of cardiovascular disease, and patients with CKD are at a higher risk for cardiovascular disease. You put the two of them together, these patients are at a really high risk, and that's why you see this really interesting epidemiologic pattern that there's a lot more patients with stage 3 CKD than stage 4 CKD because unfortunately they don't progress to stage 4, they die of cardiovascular disease. So, one issue is the progression of kidney disease in patients with CKD, but the whole other issue is the protection of the heart and the cardiovascular outcomes in these patients as well. Now, to your specific question about the limitations, one thing that we have learned in cardiovascular medicine is that the renin-angiotensin system is sort of the renin-angiotensin-aldosterone system. You do get acute effect of aldosterone lowering when you give RAS inhibitor, but then you have this mechanism of aldosterone escape. And over time, you get aldosterone escape because there are alternate pathways through which aldosterone is made. So one limitation of only giving ACE inhibitors is that you don't protect against aldosterone and other cardiovascular disease, both heart failure and in myocardial infarction. We have learned that you get incremental benefit with aldosterone blockade. That is one limitation of only giving ACE inhibitor because it's the same pathophysiology implicated in chronic kidney disease as well. The other limitation, GLP-1 receptor agonists are good for cardiovascular outcomes, but really have not shown consistent benefit in terms of the CKD benefit overall, but there are some trials going on. Maybe we'll learn more, but not as convincing data. And then SGLT2 inhibitors. I mean, you have a really a good case for prevention of progression of chronic kidney disease, and that's where there's this whole debate about the combination therapy, and I'm sure that we'll maybe discuss that.
Janet, can I come back to you with what Javed has said and bring it back to the clinical practice? Do you see any limitations the patients cannot follow, or can you smoothly introduce one by one these modern treatments?
These newer treatments, the SGLT2 inhibitors, the GLP-1 receptor agonists, and then the aldosterone mineralocorticoid receptor blockers are all amazingly well tolerated. So the good news is that we can introduce treatments that patients benefit from, and they're quite well tolerated in our patients.
And despite these current therapeutic approaches, any unmet treatment needs for patients with type 2 diabetes and CKD? Maybe this goes to both of you. And Javed, what do you think about the further unmet treatment needs we currently face?
Yeah, I mean, there are plenty of unmet needs. So one is that despite the current standard of care of risk factor management and RAS inhibition, which definitely modulates the risk and make things better, but there is a ton of residual risk that these patients are at. So certainly optimizing with more therapy is needed to further reduce the risk just by giving risk factor modification instructions and ACE inhibitor. You don't sort of obliterate the worsening kidney profile and the cardiovascular risk. But the bigger issue is actually a management issue more so than the pathophysiologic issue. There are not enough sort of endocrinologists around to take care of all diabetes patients, and traditionally, the nephrologists have been involved in more later stages of the disease. So these patients are largely in the cardiology and the primary care arena, and we don't do albuminuria assessment as frequently, and we don't identify the risk as frequently, and more so, how many people may have albuminuria despite an eGFR greater than 60. All of these things really require education for the primary care physician and the cardiology community.
So let's come to a final question to Janet. A question I've learned from Javed recently. He told me that the cardiologists like to go in with all potential organoprotective treatments in a rapidly short period of time. Do you agree with this?
So endocrinologists were early adopters of the new therapies, and we're becoming like cardiologists. If the patient needs protection from end organ damage, it is appropriate to give them the maximum protection. So most of these patients handle SGLT2 inhibitors on top of other therapies. We know SGLT2 inhibitors work even when the A1C is normal or in non-diabetics. And likewise, for those with higher A1C, GLP-1 receptor agonists have been hugely helpful. So we're becoming like cardiologists.
So thank you both for answering these nice questions in a good way. Thank you. We also want to discuss the question, why are non-steroidal MRAs being investigated in patients with type 2 diabetes and chronic kidney disease, and what do the latest data show? The rationale for blockade of MR in patients with type 2 diabetes is twofold. First, the MR gene expression controls fluid, electrolyte, and hemodynamic homeostasis. And second, the overactivation of the MR causes inflammation and fibrosis that damages the kidney and heart. In the physiological state where we have low activation, we have balanced homeostasis with electrolytes balanced, especially the sodium-potassium ratio. When it comes to MR overactivation in type 2 diabetes and chronic kidney disease, you have a dysregulation of electrolyte balance and subsequently inflammation and fibrosis and progression of kidney disease. Blockade of the MR aims to slow progression of chronic kidney disease, for example with spironolactone. But this treatment is associated with hyperkalemia and causes potassium retention. The steroidal MRA spironolactone is causing non-selective MR binding. The cardiorenal protection by MR blockade goes without causing hyperkalemia. For example, with finerenone, where we see only moderate potassium retention. This nonsteroidal MRA is doing selective MR binding. So overall, the MR overactivation is inhibited and the pro-inflammatory and pro-fibrotic gene expression is reduced. There are some questions to this introduction I have given to you. And let's go again with Janet. The question is, targeting MR overactivation is an important approach to slowing CKD progression, but use of steroidal MRAs in kidney disease is somewhat limited. Can you explain why this is the case?
So, Christoph, as you mentioned, the major problem with the steroidal MRAs is hyperkalemia, and major trials of combinations of ACE and ARBs, ACE-ARBs, and other agents and steroidal mRNAs have led to very high levels of hyperkalemia. So we have still residual risk even after the SGLT2 receptor, SGLT2 transporter inhibitors. And this is exactly where we need additional therapy like MRA receptor antagonists.
So the third generation nonsteroidal MRAs like esaxerenone or finerenone have now been developed. The question is, how do their properties differ from steroidal MRAs? So maybe before I ask you, Janet, again this question, or maybe Javed, maybe I give you a bit of a background of the esaxerenone action and trial data, for example, the ESAX diabetic nephropathy trial. And if we look at all the trials we have in the moment, which of course is Fidelio DKD and Figaro DKD, with large number of patients treated with finerenone, we have the SRXDN trial with about 455 patients with type 2 diabetes and microalbuminuria, and they were treated with the intervention versus placebo. And the primary composite endpoint was urinary albumin creatinine ratio remission. And in this trial, 22% achieved UACR remission versus placebo. So the absolute difference was 18%. There were some secondary endpoints which were also quite interesting, a minus 58% versus 8% esaxerenone versus placebo. So a potent anti-albuminuric intervention. And there was some issues of hyperkalemia, which were 8.8% of the new intervention versus placebo 2.2%. So I'm coming back to the question about this third generation non-steroidal MRA like esaxerenone and questions about the SRXDN trial. You can maybe both respond. And I start with you again, Janet.
Yeah, so the data on the SXDN trial is really encouraging. Remission of albuminuria suggests that these agents have an effectiveness that's really quite unique. However, in a microalbuminuric population, the estimated GFR is a little bit higher, and it's very concerning that we saw 8.8%, almost 9% hyperkalemia in a milder CKD population. So proof of concept with SXDN, but not quite where we want to be.
So, Javed, what do you think about the SRXDN trial?
Yeah, so as Janet mentioned, I mean, these are encouraging results, but the bigger issue here is these third generation non-steroidal MRAs. So one problem with the steroidal MRAs is the side effect profile, pharmacokinetic profile, and then the mechanism of action. So, we sometimes sort of lump all of these drugs together, but these drugs are different. So they are non-steroidal, so you don't tend to have progestational side effects like gynecomastia or breast pain or those kind of side effects. So that's one benefit. They are selective. The distribution is different, more balanced distribution between the heart and the kidneys. You have decreased risk of hyperkalemia. Spironolactone gets converted to canrenone, which is the active metabolite, has a very long half-life. Finerenone does not, has a shorter half-life. But then also there are basic science data with finerenone as well, where the receptor binding, the mode of receptor binding is different, and the gene expression is different, and more antifibrotic and anti-inflammatory benefits with these selective non-steroidal MRAs as well. So there is certainly progress in terms of benefit and tolerability with these newer generation MRAs.
So I told you, Javed, that the SRXDN trial was a smaller trial with 455 patients, first proof of concept. But the Figaro DKD and Fidelio DKD trials are much larger. So, what did they show regarding the efficacy and safety of finerenone in patients we described?
Yeah, so these were two really large programs. Fidelio targeted the higher risk, more advanced CKD population. Figaro DKD was a little bit upstream and had primary focus was cardiovascular disease progression. So both had complementary outcomes, both a composite of cardiovascular outcomes, cardiovascular death, MI, heart failure, hospitalization, myocardial infarction, and stroke. And both of them had renal progression as well, looking at 40% reduction in EGFR or end-stage kidney disease, dialysis, transplant, etc. The only thing is that in Fidelio, renal endpoints were the primary endpoint, and in Figaro, cardiovascular. And consistently across the spectrum of diabetic kidney disease, we saw benefit both for cardiovascular outcomes and renal outcomes, with the primary endpoint and the secondary endpoint being positive in both trials. Now, not only were the efficacy endpoints reached, the drug was very well tolerated. So, for instance, the incidence of hyperkalemia in the Figaro trial was around 10% or so. However, the number of times that it led to discontinuation of therapy or led to hospitalization was in around zero point 0.5 to 1% range, and the hyperkalemia leading to death was not seen at all. So, overall, very well tolerated. There were no sexual side effects that were imbalanced between the placebo or the finerenone arm, things like gynecomastia, etc. The blood pressure difference between the two arms was about 3 mmHg. So all in all, the drug was very well tolerated.
So I thank you both for your opinion on these important data. Thank you. So let's discuss how might nonsteroidal MRAs address unmet needs in type 2 diabetes and chronic kidney disease and fit into the current treatment paradigm. So let's go to the cardiovascular and renal outcome trials. Today there are 4 trials which look at cardiovascular and renal outcomes in patients with type 2 diabetes and chronic kidney disease. And the trials are Fidelio DKD, Figaro DKD with finerenone as the intervention, and DAPA CKD with dapagliflozin and Credence with canagliflozin, the latter two SGLT2 inhibitors. There are several thousand patients in these trials, and the trials have slightly different inclusion criteria based on urinary albumin creatinine ratio, albuminuria, and estimated glomerular filtration rate. And according to the patient population, they vary slightly in respect to extent of albuminuria and EGFR categories. The primary composite outcome is kidney failure, also called end-stage kidney disease. And since it's a composite, we look at 40% decline in EGFR, 50% decline, or 57% decline, which is doubling of serum creatinine. All trials met the primary composite endpoint, and the risk reduction was prominent, clinically relevant, and highly statistically significant. There were a number of key secondary endpoints, the components of the primary or composite of cardiovascular death or composite of onset of kidney failure in respect or to the primary. And these reductions due to the hierarchical testing in most trials was also significant for Fidelio DKD, DAPA CKD, and the Credence trial. So we are moving to an interesting evaluation of the Fidelio DKD and Figaro DKD, which was a meta-analysis, the combined data set in the Fidelity trial. Fidelity was the name selected for this meta-analysis. And it was to evaluate the stage of kidney disease and the efficacy of finerenone on composite cardiovascular and renal endpoint. The patient population is unique because the sample size is so large. More than 30,000 patients could be now pooled and looked at the entire totality of evidence in this large group with patients with chronic kidney disease and type 2 diabetes, all treated with RAS blockade as standard of care. The serum potassium level at inclusion was below 4.8 millimole per liter, and the intervention was finerenone or placebo in both studies. The primary composite outcome was onset of time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure, and its relationship with urinary albumin creatinine ratio and glomerular filtration rate. Overall follow-up was 3 years, and you see the relative risk reduction of 14%, which was clinically significant as well as statistically significant with a high p-value. The secondary composite endpoint in Fidelity was the onset of kidney failure and pre-specified sustained more than 57% EGFR decline, and I outlined this as a doubling of serum creatinine already before. And these values were sustained, which means a second measurement 4 weeks apart, And there was an additional endpoint, renal death. Those people who did not want to start renal replacement therapy and died were counted as renal death, but there were only a few. And all this was in relationship with UACR and estimated glomerular filtration rate. The relative risk reduction was 23%, quite prominent, with a highly statistical significant p-value, finerenone versus placebo. The safety outcomes generally were similar between the treatment arms, with a certain percentage of hyperkalemia with finerenone versus placebo. Treatment discontinuation, however, due to hyperkalemia was infrequent. It was 1.7% versus 0.6%, which is more or less translated 17 people out of 1,000 treated versus 6 out of 1,000 treated, to give a better feeling about this treatment discontinuation. So, in a sub-analysis of the Figaro DKD trial, we had people with SGLT2 inhibitor on the right-hand side and no SGLT2 inhibitor in the middle. You can see here the percent of patients at baseline with an eGFR below 60, with patients on a statin, on metformin, or on a GLP-1 receptor agonist. And finerenone had cardiovascular and renal benefits independent of and in combination with SGLT2 inhibitor, which was a change in UACR, a cardiovascular composite outcome. You see the hazard ratio, and the renal composite outcome according to a 40% decline in eGFR or a 57% eGFR decrease. So to this data, I also have a number of questions. First of all, we want to answer what are the key similarities and the differences between the trial designs for Figaro and Fidelio DKD, Credence and DAPA CKD that physicians should be aware of. And ladies first, I ask again, Janet, the key similarities and differences.
So the similarities are that all of these trials studied people with type 2 diabetes and with evidence of kidney disease. So DAPA CKD and Credence selectively studied patients with higher levels, really quite high levels of albuminuria. And we know that patients with high levels of albuminuria are more likely to show progression or rapid progression of their chronic kidney disease. Figaro and Fidelio studied a broader population, including those with microalbuminuria in Figaro, so broader spectrum of their estimated GFR and broader spectrum of albuminuria. In Figaro, the cardiovascular endpoint was primary and the renal endpoint was secondary. So there were some subtle differences also in the endpoints chosen.
So looking at the cardiorenal outcomes, including the pooled data for the nonsteroidal MRAs, will these agents benefit will there be particular patient groups, and can they address any unmet treatment needs?
Yeah, so there is plenty of unmet need in these patient populations. I mean, both in terms of the cardiovascular exaggerated risk and the progression of renal risk. Both of them definitely need something more. Remember that the Figaro and the Fidelio trial had a run-in phase where they optimized RAS inhibitor therapy. So these were the patients, and the benefits that you're seeing on optimized RAS inhibitor therapy. So clearly the benefit is targeting that residual risk. Now, as Janet mentioned, Figaro Fidelio had the lower end of the EGF, lower end of albuminuria, so a much broader population. But they only studied diabetes. Credence only studied diabetes, but at a higher albuminuria range. And DAPA CKD had both diabetic and non-diabetic CKD. So lots of unmet need in this patient population, and the incremental benefit in Figaro Fidelio that we're seeing are both for cardiovascular and renal benefit, and the subgroup analysis, granted it was a subgroup analysis, the benefit numerically, if anything, was more when the combination therapy with SGLT2 inhibitor and nonsteroidal MRAs were given. So I'm sure that there will be a lot of debate about that, but the bottom line is that patients who represent the eligibility criteria for Figaro Fidelio, in my opinion, should get this therapy and not necessarily try to bring out a subgroup within those that were studied. Those were the eligibility criteria. That's where the benefit was seen.
And did the Figaro and Fidelio trials highlight any safety consideration for the use of nonsteroidal MRAs when you go to clinical practice?
Yeah, so on average, population difference of systolic blood pressure of 3, we may not think of as a big deal, but remember that's an average. So when you have an average on many thousand patients, you don't want to take the average to the bedside. We will always be clinician and use our best judgment for any given individual patient, but by and large was very well tolerated. Steroidal side effects like gynecomastia and those things were not problems. And hyperkalemia is a known risk factor, but it's not as much as some of the other MRAs. And hyperkalemia leading to death was not seen, and hyperkalemia leading to discontinuation or hospitalization was in a minority, less than 1.5% of the population.
Let's come to the final question, and maybe Janet, you can answer this. When you think about the current standard of care in type 2 diabetes and albuminuric CKD, how might nonsteroidal MRAs be integrated in clinical practice and maybe in the future in guideline recommendations?
That's an excellent question. And I'm going to go back to earlier comments that those of us who treat type 2 diabetes with all of their attendant risks need to become like cardiologists and not hesitate to use disease-modifying therapies to slow the progression of kidney disease. And I would like to highlight the Figaro data, where there is a significant number of patients already taking an SGLT2 inhibitor, and the effect of finerenone was equivalent, if not a bit stronger, in those already taking an SGLT2 inhibitor. So I think we have a new era. We have opportunities to really slow progression of kidney disease and reduce cardiovascular outcomes.
Thank you, Janet, and thank you both for these nice answers. Thank you.